Hello everyone, can you guys hear me?
Yes, doctor.
All right, so we will continue our discussion on the gram-negative bacilli. Okay, so we have, I think, around two bacteria left in the gram-negative bacilli, and then we are done with all gram-negative organisms. Okay, and then we will discuss the gram enter. Yeah, we will have just few organisms left in the bacteria, like the mycobacteria and Ecdymalia, etc. Okay. So we were actually scheduled to start the neuro from this week, since the tutor is absent. So we may start the neuro from tomorrow or the day after tomorrow. Okay. So let's start our session. Let me share my screen. Can you guys see my screen?
Yes, doctor.
All right, so we have in the last session we discussed the gram-negative rods, which were like curved shape, right? Curved shape rods. We discussed two of them. One was left. So, what were the two important gram negative rods, which were curved shape that we discussed yesterday? Okay.
Nicola and Gigini. Main cholera. Vibrio cholera and
Yeah, Vibrio cholera was one of the
Gigini.
gram-negative. Yeah, Vibrio cholera, important cause of the cholera, right? And then we discussed the
Campylobacter jejuni.
Campylobacter jejuni, which was an important cause of bloody diarrhea, was also associated with GBS, right? All right, so these all are curved shape, right, or coma shaped. Another bacteria which is in the same group is Helicobacter. It's similar to these one, okay? This Helicobacter pylori, H. pylori, okay? All right, so important characteristics of H. pylori are, so all of these are actually oxidase positive organisms, okay? So this one characteristic is actually common between all the organisms in this group along with this curved shape, okay? So important characteristics are for the H. pylori, of course, they are gram-negative, right? It has got this curved shaped, okay? Okay, and it's also a motile organism. So it has got this flagellar movement by using these flagella. So it can propel itself. So it is motile bacteria. Okay. Another important characteristic is it is a urease positive. Again, somebody. What does the urease enzyme do?
Converts urea to ammonia.
Yeah, it converts this urea to ammonia, right? So it's one of the most important valence factor for the H. pylori. Okay, so it converts this urea to ammonia, brings the pH to the alkaline. Okay, so it increases the pH of the mm, gastric environment. All right. Should convert this urea to CO2 plus H2O. Okay. So we do an important test called urea breath test, right? So in this test, what we do is a radio label urea is introduced into the stomach. And then it's checked for any radioactivity. So if the individual has has this Helicobacter pylori, so you'll convert this urea and we'll see this radioactive level COT. Okay. Another important test is we do biopsy in the endoscopic procedures. So you can also look for the H. pylori and the endoscopy as well. Okay. All right. So these are the important characteristic of the H. pylori. Okay. All right. Who is going to tell me the clinical manifestation caused by H. pylori?
Peptic ulcer, gastritis.
Yeah, it causes gastritis. Mhm. It causes this peptic ulcer, um, peptic ulcer disease, right?
Yeah.
Uh-huh.
Duodenal ulcer, first part of the duodenum.
Yeah, it causes duodenal ulcers. Right. What else?
Malt, I think also.
Yeah, it causes this maltoma. Right. Mm-hmm.
GERD.
Yeah, it could be another clinical manifestation, right? It's also associated with gastric adenoma as well. Okay, so these are the different clinical manifestations, right? All right, so what happens is, once this H. pylori goes into the stomach, it actually attaches to the these mucus secreting cells of the gastric mucosa, okay? And then they produces a large number of a large amount of this ammonia, right? So what does the ammonia do? So it has got this urease enzyme, right, which convert this urea to ammonia, right? So this ammonia is going to first it can actually damages the mucosa, right, and also decreases the pH, right, um, and also causes this inflammatory response, which leads to gastritis, right? So it damages this mucosa and leads to the loss of this protective mucus layer. Okay. Along with that, the ammonia also neutralizes the stomach acid and allow this organism to survive, right? All right. So we have the gastric ulcer, like this peptic ulcer, and then we have this duodenal ulcer. But the mechanism of pathogenesis is actually different for both of them, right? Um, how does it causes this duodenal ulcer?
Stimulate the gastrin secreting cells of the antrum.
Sorry?
Stimulating gastrin secreting cells or glands at the
Mm-hmm.
antrum of the stomach.
Mm-hmm. So, where is this H. pylori commonly found in which part of the stomach?
Antrum.
Yeah, it's most commonly found in the intrum, right? So in the intrum, which type of cells are found?
DJ cells, D cells, J cells.
We have these delta cells or somatostine producing cells, right? So as I told you, once they attach to this mucosa, they produce a lot of this ammonia, which neutralizes this. Along with that, they produce an inflammatory response and damages this mucosa. So along with damaging these mucosa, they also deplete these delta cells or these somatostatin producing cells, right? Which are mostly located in the antrum, right? So what does this somatostatin do? What's its effect on the gastrin?
Inhibitory effect on all
Yeah,
the
so it has got this inhibitory effect, right? So
yeah.
if you have less somatostatin, so it's going to there will be no inhibitory effect on the gastrin, so you will have a lot of gastrin. And what the gastrin is going to do?
Increase the gastric acid secretion from parietal cells.
So it will increase the production of acid from these parietal cells, right? So parietal proton secretion will increase, right? So there will be a lot of acids produced, right? So there will be a lot of acids going into the duodenum, right?
Hmm.
Which is underprotected. There is no this coated mucosa. So it will produce these duodenal ulcer, right? So this is a mechanism of pathogens of duodenal ulcer, right? Okay. So for the gastric ulcer, the mechanism of pathogenesis is actually different, right? What happens in gastric ulcer? So
Usually, I think the upper part.
yeah, it's actually due to the direct damage to these. So for example, like most commonly they actually they actually colonizes this antrum, but if the disease is not treated, so it can go to the gastric body or the corpus, okay? And then it will cause this chronic inflammation, right? And so it will cause this chronic inflammation leading to this gastritis, and will also directly damage these gastric parietal cells, right? Which are found in the gastric body, right? So in case of like gastric ulcer, since these gastric parietal cells are damaged, so you will see often like it's not like from the like the pathogenesis is actually not from the action of these acids, since like in gastric ulcer you might see a normal or low acid production by these parietal since they are being damaged, right? So actually the pathogenesis and duodenal ulcer and gastric ulcer is different, and I told you the mechanism, right? So did you guys understand this concept?
Yeah.
All right. So it causes these manifestation, causing the gastric ulcers and duodenal ulcer, right? And an important manifestation is it's also associated with this B cells lymphoma, right? What is the mechanism of this B cell lymphoma? B cells lymphoma, these maltoma, malt lymphoma, they are also due to so they are also due to this chronic immune stimulation. And Helicobacter pylori infection is one of the important trigger for this chronic immune stimulation. So it actually causes this local recruitment and proliferation of T cells and B cells, right? So this chronic immune stimulation in turn causes monoclonal B cells due to this excessive stimulation by these H. pylori antigens. Okay, so it leads. The important cause of this mild lymphoma is this chronic immune stimulation due to the specific antigen produced by different viral or bacterial causes. Important trigger is this H. pylori antigens. Okay. All right. So it's also associated with gastric adenoma. Okay. All right. So there are a number of causes of gastric adenocarcinoma, right? So who is going to tell me the important causes of gastric adenocarcinoma?
Gastric ulcer.
Yeah, gastric ulcer, for example, caused by this H. pylori, right?
Yeah.
Mm-hmm. What else?
Pernicious anemia.
Pernicious anemia, like it's one of the clinical manifestation in of gastritis, especially like autoimmune gastritis. So you can say so. Important causes are this H. pylori. Another important cause is consuming high salt food, right? Also, these
Nitrosamine contained food.
yeah, nitrosamine containing compounds, for example, processed meats, tobacco, etc. Right? Obesity is also an important cause of gastric carcinoma. So it will be the clinical feature.
Early satiety,
Yeah, there will be early satiety. Perfect.
weight loss,
Weight loss, of course.
maybe abdominal pain,
Yeah, there will be this epigastric pain along with melena. You will also see a left supraclavicular or
which
umbilical lymphadenopathy, right? And histopathology, you will see there are actually two types, right? One is intestinal and one is diffuse, right? So in intestinal type, you see an ulcerated mass with these heaped up or irregular edges, right? Chelsea an ulcerated lesion with these irregular with irregular borders. You also see these intestinal like columnar cells and diffuse tab. You will see this diffuse infiltration of stomach along with signet ring cells. Right? So you have studied all these things in your GI pathology. So I just wanted to revise these things. But the important things you need to remember are these risk factors for the gastric adenoma, which are, for example, H. pylori infection, high salt foods, nitrosamine containing compounds, for example, like processed meats or tobacco. Also, autoimmune, chronic atrophic gastritis, obesity, etc. So these are the important risk factors, right? All right. So how are we going to treat H. pylori infection?
Sorry, doctor. What you said? I didn't.
What is the treatment of H. pylori?
Okay, eradication
Triple
treatment.
therapy. Yeah.
Yeah, triple therapy. So what do we give in triple therapy?
PPI.
Amoxicillin, PPI, and clarithromycin.
We give PPI.
And two antibiotics, like either amoxicillin, clarithromycin, or amoxicillin, metronidazole.
Amoxicillin and
Clarithromycin.
clarithromycin. You can also remember from CAP, okay? So this was a little discussion about the H. pylori. Now let's discuss the last bacteria of the gram-negative rods, which is our Pseudomonas. aeruginosa. Okay, so this is one of the high yield one. You are going to get a lot of question in this bacteria. Okay. So what are the important characteristic of Pseudomonas?
Gram-negative rod.
Yeah, of course, it's a gram-negative rod. So important
Nosocomial.
characteristics are it's also an oxidase positive again. Is it lactose fermenting or non-lactose fermenting?
Non-lactose ferment.
Yeah, it's a non-lactose fermenting, right? Okay. It's also catalase positive. What is the significance of this catalase positivity?
More common in NADPH oxidase negative.
Yeah, so it's
CG.
more common in patient with CGD, right? All right. They also produces two important pigments called pyocyanin and pyoverdine. Cyanine and pyoverdine. Okay, so these pigments, they actually impart this blue-green color to these colonies. Okay. So this pyocyanin, it gives this green color. This pyoverdine, and if
Green.
immunofluorescence, you can see a green yellow color. Okay. All right. So important characteristics. They are gram-negative. Okay. So they are actually resembles the other Enterobacteriaceae, but they actually differs since they are actually obligate aerobe. So they are
Oh.
obligate aerobe as well. Okay, and they also do not ferment glucose or lactose. So they are actually non-fermenters. They are oxidase positors, so they should extract their energy using oxidation of the electron transport chain. Okay. All right. This Pseudomonas is actually found in the aquatic environment. For example, like water pools or also in tap waters, etc. Okay. Um, so they are found in these aquatic environment. Okay. Also, they produce this slime layer of glycocalyx. Okay. So they're actually encapsulated and they produce this slime layer of glycocalyx. And this slime layer actually give these colonies a mucoid appearance. So so once they are established in the, for example, like in the respiratory tract, these organisms actually produce these macrocolonies, and they produces this slime layer of glycocalyx, which protect them from different immune response, for example, from antibodies, right? And they then convert into these macrocolonies, okay? So they have these different these different abilities to for permanent colonization. They have they actually convert into for example, like in first they will be in micro colonies form, but once they're established, they can actually convert to these different phenotypes, okay? And they can establish their macro colonies as well, okay? So one of the important thing is this slime glycocalyx layer. And the constituent for this glycocalyx is actually this alginate polysaccharide. So this polysaccharide actually prevents these bacteria from being phagocytosed and from being opsonized. Okay, so they should inhibit the phagocytosis and opsonization by the immune cells. Okay. All right. So these were some of the important characteristics of the Pseudomonas. Okay. Now let's discuss a number of conditions caused by the Pseudomonas. Okay. So Pseudomonas is usually more pronounced in individuals who have cystic fibrosis, right? What happens in cystic fibrosis?
They form biofilm.
Sorry.
Biofilm formation in the cystic fibrosis patients.
So you have an autosomal recessive mutation of which gene?
CGFR,
CFTR.
CFTR.
Mutation of
See,
CFTR. Cystic fibrosis transmembrane conductance regulator, this gene, right? It leads to decreased water content, for example, in the mucosa, okay? All right. Just give me a minute, okay? All right. So this in different glands we have this CFTR channel, which actually regulate the chloride channel, right? So for example, this is our sweat gland. And over here we have our pancreatic gland. Okay. So what happens in sweat gland in patient who have this gene defect of CFTR?
Is a defective sodium chloride channel.
Mhm. So what happens, for example, these are the ducts which leads the skin. For example, this is our skin, right? Over here we have these chloride channels, these CFTR channels, right? So what happens, for example, we have a lot of chloride over here along with sodium, which has got this positive charge, right? So in sweat gland, this this channel actually reabsorb the chloride, chloride, right? So for example, over here we have this channel, okay. So like these chloride channels, they are going to go in this direction over here, okay. So sodium will follow as well along with water, okay. If these channels are actually defective, so it will lead to a lot of chloride and sodium along with water excretion. So you will have a salty sweat, okay. So this is what happens in the sweat gland. In other gland, for example, in the respiratory mucosa, in the mucus gland, in the respiratory mucosa, or at the mucus gland of the intestine or the pancreatic glands, it's actually different. So in these glands, they actually secrete chloride. For example, like these are the ducts. Okay, so for example, like these are the ducts. We have these channels, for example, like the channels is were right over here, right? So these glands actually actively secrete these chloride ions into these ducts in order to make this mucus smooth, okay? So for example, these are the chloride channel, these are the sodium channels. So they'll secrete these chloride ions into these ducts. So sodium will follow and also water will follow. So the mucus will be thin, right? But if these are defective, so no chloride channel will be secreted into these ducts, so the mucus will be very thick. Okay, so you'll have very thick mucus. So same happens in all of the other glands all over the body, right? You have decreased water contents, which causes this thick and viscous mucus. Okay. So what will be the clinical manifestation?
Recurrent infections.
Yeah, so there will be recurrent recurrent sign of pulmonary infection. Okay. With a lot of different pathogens, for example, Staph aureus or Pseudomonas and other bacteria, right? You'll have a chronic productive cough. Right?
Pancreatic insufficiency.
Yeah, it can also cause pancreatic insufficiency. All right. What else do we have in cystic fibrosis?
Infertility.
Yeah, infertility. Why?
Absence of vas
Abs-
deferens.
Yeah, in male, there is congenital absence of vas deferens, right? Also in female, it will produces the cervical mucus production. So it can also lead to female fertilities as well. Okay. Okay, so what will be the clinical signs and symptoms in patient with cystic fibrosis? So they'll present with sinusitis. They'll present with this recurrent sinopulmonary infection, for example, pneumonia, etc. Rhinosinusitis. Also, with time, it will lead to bronchiectasis, right? Because there is, for example, with infection from Pseudomonas aeruginosa, they produce a lot of enzymes, for example, like elastase, phospholipase C, etc., which damages these mucus wall, right? Patient will have cachexia. They'll not be able to fail to gain weight. Okay, there will be biliary cirrhosis.
Sorry.
Patient present with pancreatic insufficiency, right? So what do we give in like in patient with pancreatic insufficiency?
Pancreatic enzymes.
Yeah, we give, they'll need pancreatic enzyme supplementation, these different enzyme, for example, pancreatic lipase, all these things, right? Since there's insufficiency of the pancreatic enzymes, right? They will present with steatorrhea, and because there is small absorption of uh, um, different nutrients. Okay. All right. So these are some of the clinical manifestation in patient with cystic fibrosis, right? So you have a lot of questions that cystic fibrosis related to the Pseudomonas. Okay. All right. So, cystic fibrosis, individual with cystic fibrosis, they're actually different bacteria, but the common one are Pseudomonas aeruginosa, which causes manifestation in individual with cystic fibrosis in the staph aureus. Okay, so these two bacteria is actually important. Okay, but for example, in children, you will see a lot of staph aureus infections. Okay, staph aureus as well as H influenza. But in adults who are the age of 20, you have a lot of Pseudomonas aeruginosa. Okay. So over the age, you should be able to differentiate between these different, for example, like respiratory infection. You should be able to differentiate infection. So in adults, Pseudomonas aeruginosa is more pronounced, and in children, for example, like from age 2 to 20, you will have more of the H influenza or staph aureus infection. Okay. All right. So this was a little discussion regarding the related to the cystic fibrosis. Okay. Okay. So what other clinical manifestations, diseases are caused by Pseudomonas aeruginosa? It causes this nosocomial infection, for example, pneumonia. Okay, and it's actually very hard to treat. Okay, the normal infectant actually does not work against Pseudomonas, and so it is one of the important cause of these different nosocomial infection. Okay, it also causes osteomyelitis, especially in people who are diabetic. Okay, are in IV drug users. So the important risk factor for Pseudomonas aeruginosa are, for example, those who have, it's actually more pronounced in people who are hospitalized. Okay. For example, extensive burn. It can directly go to the blood. Okay, since there is no skin barrier. Okay, and no host defenses. Patient who have chronic respiratory diseases, for example, cystic fibrosis, right? It's one of the important risk factor. And also those persons who are immunosuppressed. With neutrophil count less than 500. And also an indwelling catheter use. So these are the important risk factor for Pseudomonas aeruginosa. So it causes osteomyelitis in people who are IV drug users, since this Pseudomonas can directly go into the blood and spread to the bones, and also in diabetics. Right. All right. Burn patients, they are actually very susceptible to infection by Pseudomonas aeruginosa, right? So if they give you questions, a person presenting with burn, so your first pick should be Pseudomonas, okay? Within dwelling catheter, it's one of the important cause of nosocomial UTIs, okay? It also causes a skin disease called hot tub folliculitis. So, for example, like those waters, pool water, which are not chlorinated, they can be an important reservoir for the Pseudomonas aeruginosa. So they can cause this hot tub folliculitis. It's also called pruritic folliculitis. So you will see these pruritic papules, okay, in patient with this pruritic folliculitis. And this pool water is actually an important cause. Also, no chlorination of water. It also causes a skin condition called ecthyma gangrenosum, especially in patients who are immunosuppressed, who have an absolute neutrophilic count less than 500. They can cause this ecthyma gangrenosum. So these are these black necrotic lesions. Okay. Another important manifestation is otitis externa or swimmer ear, which can also lead to malignant otitis. You will have this granulation tissues. Okay. All right. So there are a lot of number of toxins produced by Pseudomonas aeruginosa, but the important one is this exotoxin A. Okay. And how does this exotoxin A work? We have already discussed this one. So it causes ribosylation of elongation factor 2 and halt protein synthesis and causes cell death. Okay. And there are also a number of other toxins as well, but this one is actually important. It says the same mechanism of action is that of diphtheria, right? We discussed that one. What is the treatment of Pseudomonas?
Gentamicin.
Mm-hmm.
Piperacillin, Azoxystrobin.
Yeah, VKO, anti-pseudomonal antibiotics. So there are a lot. Okay. So for example, we can give anti-pseudomonal penicillin, for example, piperacillin or ticarcillin, etc. Okay. You can also give aminoglycosides. We can give cefepime or ceftazidime, third or fourth generation cephalosporin, okay? And also we can give fluoroquinol, okay? So piperacillin, third or fourth generation cephalosporin can also be given. All right, can you aminoglycosides and fluoroquinolones and monobectam and carbapenems. So these are all actually anti-pseudomonal antibiotics. So this was all about the Pseudomonas aeruginosa. So did you guys understand? Do you have any questions? All right, no questions. So let's discuss the MCQs. So who is going to read the first question for us?
Which of the following microbe-induced mechanism is the most likely underlying cause of the findings seen in this patient? 60-year-old woman comes to the clinic due to worsening dyspepsia and unintentional weight loss over the past 3 months. Vital signs are normal. There are no cervical or inguinal lymphadenopathy. Abdominal examination shows mild epigastric tenderness. CBC and serum chemistry results are normal. CT scan of the abdomen reveals gastric mucosal thickening, but no evidence of abdominal lymphadenopathy or hepatosplenomegaly. Endoscopy shows a nodular gastric fold, and biopsy shows proliferation of a small clonal mucosal associated B cell expressing the CD20 antigen. Which of the following microbe-induced mechanism is the most likely underlying cause of the findings seen in this patient?
So this patient is having dyspepsia along with unintentional weight loss, okay? And under endoscopy, you see nodular gastric folds, and biopsy shows these small clonal mucosa associated B cells expressing the CD20, right?
Hmm.
So it's a case of malt lymphoma, right?
Yeah.
So what is the correct option?
Chronic immune stimulation.
Chronic immune.
Yeah.
Chronic immune stimulation, right?
Yeah.
So I told you there are different triggers for the mild lymphomas. Okay. One of them is there are like different bacterial, viral, or autoimmune conditions, but one of the important trigger is this H. pylori infection, right? So in H. pylori, they produce a lot of antigens, which causes chronic stimulation of these B and T cells. Okay, and this chronic stimulation, immune stimulation of these B and T cells actually leads to the production of these monoclonal B cells, which leads to this mild lymphoma, right? All right, let's go to the next question.
Which of the following findings is also likely to be present on autopsy? An 18-year-old man is admitted to the hospital with cough, fever, and hypoxemia. Despite multiple IV antibiotics and frequent chest physiotherapy, the patient decompensates and is transferred to the ICU for mechanical ventilation. Sputum culture grows more than 100,000 colony forming units of a non-lactose fermenting gram-negative rod. After several days, the patient dies of overwhelming pneumonia complicated by respiratory failure. Since age 1, he had been hospitalized for recurrent episodes of multilobar pneumonia, sinusitis, and poor growth. On autopsy, both vas deferens are absent. Which of the following findings is most likely to be present on autopsy? It is a case of cystic fibrosis, right?
Yeah, it's a
And
case of cystic fibrosis. Because he has these recurrent infection, he has poor growth because of the pancreatic insufficiency, sinusitis, voice difference or absence. These are important clues for the cystic fibrosis, right? So correct option is
Option A.
A.
Distension obstruction of
yeah,
pancreatic.
you have obstruction all over the body in different ducts of the body with in cystic fibrosis patient, right? Digestion and obstruction of pancreatic duct is the correct option, right? In which condition do you see situs inversus?
Cartaginer syndrome.
Cartagena syndrome.
Yeah, Cartagena syndrome. So clinical feature of CF, respiratory, you have obstructive lung diseases, bronchiectasis. So there's a lot of damage going on due to the different enzymes produced by different bacteria. Recurrent pneumonia, rhinosynovitis, GI manifestation or obstruction. Patient present with meconium ileus. Okay. Distal intestinal obstruction syndrome. Then you have pancreatic diseases, exocrine pancreatic insufficiency. Also, you can see CF-related diabetes, biliary cirrhosis. Patient can also have infertility, MSK, osteopenia, K4 scoliosis, and digital clamping. All right, next question.
Which of the following part of the history is most likely to reveal the cause of this patient's current condition? A 69-year-old man is evaluated for abdominal pain. Upper gastrointestinal endoscopy shows a single shallow 1 centimeter ulcer in the duodenal bulb and midgastric erythema. Biopsy specimens from the gastric antrum do not show Helicobacter pylori, and the stool testing of H. pylori antigen is negative. Which of the following parts of the history is most likely to reveal the cause of this patient's current condition?
Uh-huh.
Medications.
Yeah, so this patient has peptic ulcers, right? And he has no H. pylori infection is shown by this biopsy specimen, and also stool antigen tests are also negative, right? So what could be the other important cause for the peptic ulcers?
Medication use NSAIDs.
Yeah, NSAIDs use. So two important causes for peptic ulcers are H. pylori infection and non-steroidal anti-inflammatory drug use, right?
Yes.
All right. Next question.
Depletion of these cells from the gastric antrum is most likely to cause which of the following condition? Researchers studying gastrointestinal pathophysiology analyze hundreds of gastric mucosal biopsy specimens taken from the patient who underwent endoscopy at a local tertiary care center. They noticed that the colonization of gastric antrum with S-shaped gram-negative bacteria is associated with decreased number of somatostatin-producing antral cells. Depletion of these cells from the gastric antrum is most likely to cause which of the following conditions?
Uh-huh. So these patients have this H. pylori, right, which are associated with decreasing number of these delta or somatostatin producing antral cells, right? So what is the correct option?
See, this gastric lymphoma.
No.
No?
Duodenal ulcer.
Sorry?
B.
Yeah, I told you there are two types of ulcers, right? Duodenal and peptic ulcers, right? And the mechanism of pathogenesis is actually different. And duodenal ulcer, what happens is these H. pylori actually damages these somatostatin producing antral cells, leading to a lot of gastrin, which work on the parietal cells and produce a lot of acids, which these acids are emptied into the duodenal cells, which is underprotected and causes duodenal ulcers, right? The other type of ulcer was this gastric ulcers, which is due to the direct damage of these H. pylori cells, right? H. pylori bacteria. So correct option is duodenal ulcer. Did you guys understand?
Yes,
Yeah.
yes, we got it. No, yeah, good. I was not in the class in the start. Yeah, got it. Thank you.
Yeah, so you have H. pylori, which damages these somatostatin enteral T cells, increase a lot of gastrin and produces secretion of these acids, which are emptied into the duodenum and causes these duodenal ulcers, right? Okay, next question.
The underlying cause of this patient's current condition can also lead to which of the following? A 36-year-old woman comes to the office due to vague epigastric abdominal pain, occasional nausea, and bloating. She has no associated weight loss. Medical history is notable for moderate obesity and chronic allergic rhinitis. The patient takes no medications and does not use tobacco, alcohol, or illicit drugs. She was a vegetarian for several years but now consumes a wide variety of foods, including meat products. The patient has traveled abroad extensively in the past. Vital signs are normal. Examination shows mild epigastric tenderness to deep palpation. Lab results reveal mild anemia. Upper GI endoscopy shows diffuse erythema of the antral mucosa. Biopsy reveals an inflammatory cell infiltrate involving the superficial mucosal layers. The underlying cause of this patient's current condition can also lead to which of the following?
Mhm. So what does this patient has?
Wake abdominal pain.
So this patient has gastritis, right? There is this diffuse erythema of the antral mucosa, right? Biopsy reveals an inflammatory cell infiltrate involving the superficial mucosal layers, right?
Yes,
So
I thought she has ulcer, so no gastritis.
yeah, she has
Okay.
gastritis, right? It's shown by this upper this upper gastrin intestinal
Endoscopy.
endoscopy,
Yeah,
right?
yeah.
So um correct option is
A.
yeah
Gastric lymphoma.
Gastric.
yeah gastric lymphoma, right?
Mm.
So if there is chronic immune stimulation of these B cells and T cells, it can actually it can actually lead to gastric lymphoma, right? Okay. So, atrophic gastritis, there are two types, right? Which is one is H. pylori induced and one is autoimmune, right? So H. pylori, it will be multifocal patchy. It will like spread throughout the stomach, right? The intrum as well as in the body, etc. In the autoimmune, you will see, especially this in the body of the stomach. it will be diffuse, okay? And it will spare the interim. Inflammatory cell will be neutrophil, plasma cells, and lymphocytes. And autoimmune, you see lymphocyte and macrophage. Gastrin level in H. pylori induced gastritis may be normal or maybe high, okay, if those delta cells are damaged. In autoimmune, you will always have a high gastrin level. Acid production may be normal or maybe low, okay. I told you the reason. In autoimmune, it will be normal. Sequelae gastric ulcer and autoimmune, you'll see vitamin B12 for pernicious anemia, okay? Associated with adenocarcinoma or mild lymphoma, and autoimmune is associated with adenocarcinoma. Risk factors: living in resource limited and other autoimmune diseases. All right, next question.
Biopsy of which of the following site is most likely to demonstrate the infectious agent responsible for this patient's current condition? 34-year-old man come to the office due to upper abdominal pain. The patient has a vague discomfort that happens mostly in the afternoon and at night and is partially relieved by food. He sometimes feels nauseated and he has had no vomiting, black and bloody stool or weight loss. The patient has no prescription or over-the-counter medication. Family history is negative for cancer. Upper gastrointestinal endoscopy revealed a small ulcer with a clean base in the duodenal bulb. Biopsy of which of the following site is most likely to demonstrate infectious agent responsible for this patient current condition?
So,
So
what
it's
condition
biopsy.
is patient
It's
having?
duodenal ulcer.
Yeah, duodenal ulcer, right? There is a small ulcer in the duodenum, and also the pain is partially relieved with food and gastric ulcers. With food, the pain will increase or decrease.
With decreases with the duodenal ulcer, pain with the food decreases.
Yeah, it's relieved
And
with the
gastric
food.
ulcer increases.
Yeah, it increases, right? So biopsy of which of the following site is most likely to demonstrate?
Duodenal?
Antrum.
Antrum.
Antrum. Yeah, antrum.
Yeah, antrum. I told
Gastric
you.
antrum.
Yeah.
Yeah.
Okay. Next question.
This test result suggests that which of the following process is occurring. A 56-year-old man comes to the office for evaluation of upper abdominal pain occurring with meals for the past month. The symptoms improve when he is fasting. The patient has a history of CAD and osteoarthritis. Current medications include aspirin, simvastatin, and acetaminophen as included. He drinks 1 to 2 beers daily but does not use tobacco or recreational drugs. Upper endoscopy reveals a gastric ulcer with smooth, rounded border and an exudative base. The biopsy specimen of the ulcer is placed in the solution containing urea and phenol red and a pH indicator. 30 minutes later, the solution turns pink, indicating a pH increase. This test suggests which of the following is occurring.
So correct option is
C.
sorry.
C.
Yeah, correct option is C, enzymatic production of ammonia, right? So H. pylori has this urease enzyme, which is an important valence factor as well. It converts this urea to ammonia, which neutralizes the pH and bring the pH higher, right? So enzymatic production of ammonia is the correct option.
Doctor, why not D?
Gastrin, no, they are actually asking about the test result, right? Not
UVT.
the Mm.
Test result, yes. Yeah.
Not about the pathogenesis of the disease. All right, next question.
Yes.
Which of the following most likely predisposed this patient to his current condition? A 70-year-old man comes to the office due to persistent epigastric discomfort and nausea for the past several months. He has also noticed black colored stool on several occasions. Medical history is notable for hypertension and osteoarthritis. The patient immigrated from rural China 5 years ago to live with his daughter. He does not use tobacco, alcohol, or illicit drugs. Physical examination shows a thin male with pale mucous membrane and enlarged left supraclavicular lymph node and epigastric tenderness on deep palpation. Stool testing for occult blood is positive. Upper GI endoscopy reveals a 3 cm ulceration at the gastric antrum with a heaped up irregular border. Biopsy from the edges of the ulcer reveals granular structure containing intestinal like columnar cells. Which of the following most likely predisposed to this patient's current condition?
So, what does this patient has?
Gastric cancer.
Yeah, gastric adenocarcinoma, right?
Adenocarcinoma.
Intestinal pipe.
Yeah. So he has gastrointestinal endoscopy, which revealed this 3 centimeter ulceration, the gastric antrum with these irregular borders, right? And also the glandular structure containing intestinal columnar cells. It's specifically the intestinal type, right? So, and he is also from China. Okay. There is these enlarged virtual nodes, melena, these different clues for the gastric adenocarcinoma. So, correct option is
B.
B.
yeah, then excessive consumption of salt preserved foods, right? So I told you the different some of the risk factor for the gastric adenocarcinoma. So what were these?
H. pylori infection and consuming high salt food and
Yes.
nitrosamine containing compounds and obesity.
Perfect. Yeah, that's right. And also autoimmune chronic gastric atrophic gastritis. So you should remember all these different risk factors since you are going to be tested on all of these things. Okay. So these are the risk factor clinical features. We have early satiety, weight loss, epigastric pain, melena, and this left supraclavicular umbilical lymphadenopathy. Right. All right. Next question.
Which of the following agents is most likely to improve this patient's condition in long term? A 14-year-old boy is brought to the physician by his mother due to chronic diarrhea and failure to gain weight properly. He has a recent history of recurrent respiratory infections and prior sputum cultures have been positive for Pseudomonas aeruginosa. His younger brother has died from a severe respiratory infection at the age of 7. Which of the following is most likely to improve his patient's condition in long term?
What condition is this patient having?
Cystic fibrosis.
Cystic fibrosis.
Cystic
Yeah,
fibrosis
cystic
with
fibrosis.
superimposed with Pseudomonas.
Yeah, and he has like failure to gain weight appropriately, recurrent respiratory infections are there, and he's also positive for Pseudomonas aeruginosa, right? So in cystic fibrotic fashion, you have pancreatic insufficiency. So which drug we will give?
E. Pancreatic lipase.
Yeah, pancreatic lipase is the correct option. All right, next question.
Which of the following would be most appropriate to prevent ulcer recurrence based on this patient? Most likely diagnosis. A 34-year-old man comes to the office due to epigastric pain. He has had the pain for several months and describes it being worse at night and relieved by eating. The patient has no significant medical history and takes no medications. He doesn't use tobacco, alcohol, or recreational drugs. The patient immigrated to the United States from China 4 years ago. Vital signs are within normal limits. Physical examination shows mild epigastric tenderness to the palpation. Labs demonstrates iron deficiency anemia and presence of fecal occult blood. Upper GI endoscopy reveals 1 centimeter ulcer in the first portion of the duodenum. Additional test results are pending. In addition to PPI therapy, which of the following would be most appropriate to prevent ulcer recurrence based on this patient most likely diagnosis? Antibiotics.
Yeah, antibiotic.
Yeah.
All right, next question.
Which of the following microbiological characteristic best describe the infecting organism? A 73-year-old man come to physician complaining of progressive severe pain and discharge from her left ear for the past 2 days. She has had type 2 diabetes for many years and has been non-compliant with her medication and follow-up appointment. On examination, moving and touching the pinna produces extreme pain. Otoscopic examination show granulation tissue in the left ear canal with a scant amount of discharge. The tympanic membrane is clear and there is no middle ear effusion. Initial culture from the ear show a gram-negative rod. Which of the following microbiological characteristic best describe the infective organism?
So what condition?
Pseudomonas.
So what condition is this patient presenting with?
This otitis externa.
Yeah, a malignant otitis externa, right?
Yes.
Okay, so correct option would be
Option C.
Motile and oxidase positive.
motile and
Motile is
No, it was motile or not? I don't know. I forgot.
yeah,
Is it motile?
motile.
non-motile and lactose non-fermenter, I think.
Yeah.
No. Option
No,
C is correct.
motile and oxidase positive is the correct option, I think.
Pseudomonas is motile also.
Yeah, it's also motile.
Yeah, it was, I think, catalase positive, oxidase positive, and motile gram-negative.
Yeah, that's right. Fast lactose fermenter is which one?
Klebsiella and Enterobacter.
Yeah, Klebsiella and E. coli and Enterobacter, right?
Yeah.
Comma shaped and grows well in pH.
Vibrio cholerae.
Vibrio cholerae.
Vibrio cholerae, right? Non-motile and a lactose non-fermenter.
H.
Shigella.
coli.
Yeah, Shigella, right? That was non-motile. Salmonella was motile, right? Requires factor 5 and 10 for growth.
Hemophilus.
Hemophilus. All right, next question.
Which of the following bacteria was most likely found in this study? Investigators studied the prevalence of respiratory pathogens in patients with cystic fibrosis across the age spectrum. It is found that age is a strong predictor of colonization by a specific microbe, as shown below. The pathogen, once acquired, often switches into mucoid phenotype, which is able to produce an alginate containing biofilm matrix that helps to establish chronic infection. Which of the following bacteria was most likely found in this study?
So what do you see on this graph?
That it's increasing with age. The
Yeah, so the colonization actually increases that. So on the y-axis you have percentage of individual, and on the x-axis you have age, year. So 20% of individuals with cystic fibrosis like before the age of, you can say, like 20. So 20 to 30% of people are colonized between the age of 2 to 20, right? But as the age increases, you see a lot of percentage of individual with colonization by this bacteria, right? So
Yes.
I told you, also there was this another group of organisms which were colonizing in
It's
children.
cystic fibrosis in children was Staph aureus, and in adults is Pseudomonas.
Yeah, that's right. Okay. So correct option over here is
C. Pseudomonas.
Pseudomonas regional, right? So the other graph is for Staph aureus, and as the age increases, colonization by Staph aureus decreases, right? And as the age increases, colonization by Pseudomonas after the age of 20, it increases. Okay. All right. Next question. Okay.
Which of the following is most likely cause of this patient autopsy findings? A 19-year-old man with a history of chronic lung problem dies due to respiratory distress after a prolonged episode of pneumonia. Autopsy showed dilation of bronchial tree which extend almost to the pleural surface. Many of the small airways are filled with a mucin plug containing abundant inflammatory cells and debris. Which of the following is most likely cause of this patient autopsy findings?
Mm-hmm.
It's
So
cystic
correct.
fibrosis,
Yeah, it's a cystic fibrosis. So
impaired clearance of airway secretions, D.
yeah, impaired clearance of airway secretion is the correct option. All right, next question.
Which of the following is the most likely cause of this patient's recurrent infections? A 7-year-old girl is brought to the emergency department due to 2 days of fever, productive cough, shortness of breath. Medical history significant for recurrent lung infections and cystic fibrosis. Weight is at 5th percentile. Temperature is 100.6 degree Fahrenheit. Pulse is 104 and respirations are 30 per minute. The pulse oximetry is 86% of the room air. Examination shows a very thin wall with digital clubbing and a expanded chest. Diffuse wheezes and crackles are present bilaterally. The rest of the examination is unremarkable. Chest X-ray reveals hyperinflation, chronic interstitial changes, and an infiltrate in the right lower lobe.
So which of the following is most likely cause of this current infection? So what do you think?
Pneumonia caused by Pseudomonas.
Yeah, lower lobe, right lower lobe is one.
Yeah, so this patient is having cystic fibrosis and also gram staining of the gram positive, gram negative rods, most likely cause of this patient recurrent infections. So what do you think?
Development of bacterial macrocolonies.
Development of bacterial macrocolonies. That's the correct option. So I told you, once they establish in the respiratory tract, they actually produces this alginate containing biofilm, okay, and then they convert into these bacterial macrocolonies, okay. All right, next question.
Eczema
A
gangrene.
55-year-old woman comes to the emergency department with fever and chills. She has a history of acute myeloid leukemia for which she is receiving chemotherapy. Her temperature is 38.3 centigrade, blood pressure is 90/50, pulse is 124, and respiration are 22. Physical examination is notable for multiple skin patches with necrotic centers and occasional ulceration as shown in the image below. So complete lab results are as follows. Complete blood count, platelets 240, leukocyte 800, neutrophil 60%, creatinine 0.9, prothrombin time 12 seconds, APTT 33 seconds. Blood cultures are drawn. Which of the following organism is most likely responsible for this patient's symptoms?
Okay, so what do you see on this picture?
Eczema gangrenosum, necrotic cutaneous symptom.
Yeah, you see these necrotic lesions, these black necrotic lesions, which are caused by Pseudomonas aeruginosa. An individual who are immunosuppressed, who have an absolute neutrophilic count less than 500. Yeah. So these black necrotic lesions called ecthyma gangrenosa. Yeah, so if you see the leukocyte count, it's 800, neutrophil are 60%. So the absolute neutrophil count is, so if you calculate that, so it is percentage of neutrophil multiplied by leukocytes divided by 100%, 100, right? So we have 60 multiplied by 800 divided by 100, right? So it's like 0.6. 10 to 60 is equal to 480. Alright, so its absolute neutrophilic count is lower than 500. Is immunosuppressed. So I told you, immunosuppressed individual are usually more exposed to infection by Pseudomonas aeruginosa. Okay, all right. Next question.
Gram stain of this wound the wound tissue is shown in the image below. A 65-year-old man is admitted to intensive care unit with a second and third degree burn over 25% of his total body surface area. Intravenous fluid and analgesics are administered and his wounds are cleaned and debrided. After 7 days, the patient develops a fever and his leukocyte count rises to 16,000 cells per microliter. Examination of the burn on his left leg shows surrounding warmth, erythema, and induration. Gram stain of his wound tissue is shown in the image below. Culture on the Mekonghi agar show oxidase positive colonies that do not ferment lactose. Which of the following is best initial treatment for this patient? Is this Pseudomonas?
Yeah, it's Pseudomonas. I told you, burn patients are very, very prone to by infection by Pseudomonas, right? So correct option would be?
Option A, cefepime.
Yeah, cefepime and ceftriaxone. They are first line. Okay. Next question.
they are like a multi-drug resistance. They usually doesn't respond to the other antibiotics. This the routine
Yeah,
antibiotics.
yeah, we will only give anti-pseudomonal antibiotics. For example, you can give anti-pseudomonal penicillin, like ticarcillin or piperacillin, and other cephalosporin, which are effective against the pseudomonas. You can also give monoglycosides or fluoroquinolone. Okay.
Okay.
Okay. Next question.
Sputum culture from this patient is most likely to yield which of the following organisms? A 22-year-old woman comes to the office due to worsening cough. The patient has been coughing every day for the past several months, but over the last 4 weeks, the cough has worsened with increased amount of thick sputum and shortness of breath. Streaks of blood have been present in the sputum on several occasions. The patient also has a history of chronic sinusitis and repeated hospitalization for airway infections. She takes pancreatic enzyme supplements for chronic diarrhea. She does not use tobacco, alcohol, or illicit drugs. Physical examination reveals nasal polyps, a barrel-shaped chest, bilateral coarse lung crackles, and digital clubbing. Chest X-ray shows hyperinflated lungs and dilated thickened airways. Sputum culture from this patient is most likely to yield which of the following organisms?
So look at the age of the patient. It's 22-year-old woman, right?
Yes.
So as the age increases, ionization by Pseudomonas aeruginosa increases, right? So correct option
Yes.
would be?
Pseudomonas.
D.
Yes, right. Okay, next question.
Which of the following is most likely source of this patient's infection? A 35-year-old woman comes to the emergency department due to an itchy rash that appeared earlier this morning. She recently returned from a family vacation at a resort in Cancun. 2 days ago, the patient's husband developed similar symptoms. The patient has no significant past medical history and takes no medication. She has no known allergies. Her temperature is 37.6 centigrade. On examination, there is diffuse pruritic papillopustular rash that is most noticeable on the trunk and extremities. Microbiological analysis of a pustular fluid sample demonstrate oxidase positive, gram-negative rods that produce pigment on culture medium. Which of the following is most likely source of this patient's infection?
So what condition is this patient presenting with?
Erythema.
Hot tub folliculitis.
Yeah, hot top.
And
Of
water.
No, water.
Yeah, Pseudomonas aeruginosa, causing the hot top folliculitis with these diffuse pruritic papillopustular rash, which is most noticeable on trunk, right? I think we had a first aid page on the Pseudomonas, which will actually help you remember all these diseases. So yeah, let's just quickly go through this one, okay? So aeruginosa, aerobic, motile, catalase positive, gram negative, non-lactose fermenting, oxidase positive. Frequently found in water, increased violence in acidic environment, has a grape-like odor. Pseudomonas, you can use this as a mnemonic, okay? The P stands for pneumonia, S for sepsis and gram negative, E ecthyma gangrenosum, U UTI, D diabetes, osteomyelitis, M mucide, polysaccharide, O otitis externa semiaire, and nosocomial infections like pneumonia and UTIs, etc. Intravenous drug users, then you have these skin infection like hot tub folliculitis, wound, etc. Mucoid polysaccharide capsule. Okay. Oh. Myocardial polycystic capsule may contribute to chronic pneumonia and patient cystic fibrosis due to biofilm. Reduces pride, phospholipase C, endotoxin, exotoxin A in these green pigments. Corneal circulatitis and contact lens wearers. Thymogranosome, rapidly progressive necrotic continuous lesion caused by Pseudomonas bacteremia, typically seen in immunocompromised patients. Treat with anti-pseudomonal penicillin in combination with beta-lactamase inhibitor, piperacillin, tazobactam. There are in fourth generation like ceftazidime and cibipine. Manobactam, fluoroquinolone, carbapenem. Aspire anti-pseudomonal activity, immunoglycoside monotherapy is avoided due to poor performance in cytokine. Okay. So correct option here would be
Cool water.
Yeah.
cool water. Right, perfect. So the rash will look like this. Okay, pruritic papulopustular rash. All right, next question.
Which of the following pathogens is the most likely culprit? 39-year-old paraplegic man with indwelling bladder catheter comes to the emergency department complaining of 24 hours rigors, nausea, and vomiting. Temperature 39.8. Physical examination shows suprapubic and costovertebral angle tenderness. Urinalysis shows 3% glycoside strays and numerous white blood cells. Urine and blood cultures grow non-lactose fermenting gram-negative rods. Which of the following pathogens is most likely culprit?
Oh, correct option is
Pseudomonas.
Pseudomonas aeruginosa. Why it's not E. coli?
Because of the characteristics,
Nitrite.
right? Not
E.
Non-lactose.
coli is
Nitrite.
lactose ferment.
Yeah, E. coli is lactose fermented. Right? All right, last question.
The toxin responsible has a mechanism of action most similar to another toxin produced by which of the following bacteria? 3 cases of severe pharyngitis were reported in a community of immigrants. The patient had a thick pharyngeal exudate, neck swelling, and difficulty swallowing. One of them died from severe heart failure. The toxin responsible has a mechanism of action most similar to another toxin produced by which of the following bacteria?
Mm-hmm. So,
Endocarditis. This
Pseudomonas.
is Pseudomonas.
Pseudomonas.
yeah, it's
Elongation factor.
C. diphtheria, right? And as I said,
Yes.
mechanism of action is that of Pseudomonas aeruginosa, EF2 ribosylation. So this was all for today. Do you guys have any questions?
Sir, I have a question. So it's almost end of November. Can you briefly tell what is the next plan for this course?
Yeah, so we are going to start neuro from tomorrow, okay, and we'll also do the microbiology along the course. We'll do like maybe 1 to 2 days every week, okay. Along with that, we'll cover the micro with the neuro. So neuro will take around 7 to 8 to 9 days. Then we have repro, and then we'll also do some of the general principles as well.
And what about the timing? Would it possible to start little earlier so then we can cover 2 things? Otherwise, it's if we will be having a neuro class and along with micro. So if we start 1 hour early, so then we can cover. Otherwise, it's little hard for us to take the
Yeah.
class.
So, yeah, I'll see if we
Yeah,
can adjust.
sometimes like we cannot get this like the video on time, then we are not going in the stream. Then we miss the things and the things go ahead and the previous is just like the things are lagging and if it's possible to start little early so that it will help most of the student.
Yeah, I'll see if we can adjust the timing. Okay. But
So,
there's,
sir,
Thank you.
yes.
basically, you are saying from tomorrow we are going to have 2 classes every day?
No, not every day. We'll do like maybe 1 to 2.
1 to 2. Okay.
Yes.
And
Yeah.
and with this speed, like with this thing, I think it's gonna take by this course is going to be finished by the end of December.
So yeah, I think today is 24th of November, right?
Yes.
So till 1st, 2nd December we'll cover the neuro. Then we have repro, which is very short. And then we have general principle, which will not take a lot. So maybe we can expect it till mid of December.
Okay. Thank you so much, sir. Thank
Yeah.
you. Thank you. Yeah. Thank you so much.
All right. Anyone else who has any questions?
Just doctor, if you change the timings, then you will change it for the September batch too, right? Like,
Yeah,
because like
we'll
otherwise they
change.
will coincide. Yeah.
Yeah, we'll change for the September batch as well if we decide to change the time.
Okay, and please can we get the recordings every day? It's been a it's it's like putting hindrance in our preparation that way because we have to ask many times. In Ace World it's good. Sometimes in the other batch the recordings are really delayed. And
Yeah, I do share the recordings like just after the lecture, but the
yeah,
problem is with the September batch, Dr. Kumar,
yes.
he is like I think he is the match interview going on. So he shared like sometimes he shares a little late. I'll talk to him and we'll share the recording on time.
Yeah, please, if it can be every day, because sometimes we miss it, and even if we attend the class, sometimes I want to revise, but we're not able to do that. So please, if it can be every day, it will be very helpful.
Sure. I'll talk to him and we'll share the recording on time. Okay.
Thank you.
All right. So thank you so much for joining. I hope you enjoyed the session. Have a great day ahead. Bye. Take care.